Let me time out there if you don't mind. With today's concealed weapons laws, and Oklahoma is constitutional carry. I'm not sure about Texas, but there are a lot of people carrying. So that's something that, whether it's medical or trauma, we have to deal with that. So
you as an EMT remove their weapon?
You don't want them. You don't want them going with you with it. So we involve law enforcement there to remove, secure, convince them that it's in law enforcement custody. It's not to be taken into the hospital. Those are gun off limits to guns, hospitals and healthcare facilities. Please refer to your SOG, SOP at your department, because you will encounter those that are on there. If they're carrying an appendix carry, get in a massive car accident, they're unconscious, there it is. You got to do something with it. You got to do something. So, yes. I'm not supposed to tell you to touch it or remove it, because
I'm saying if you do remove it, you're not allowed to have a gun in the hospital.
Right. So hospital security, help me, hospital people.
Hospitals, I mean, usually law enforcement's going to be the one to take it, but hospital security can take the weapons and secure them.
Just involve that other step of
I
person.
think even if firearms, Jordan might know later about that. She's still there, but firearm-wise, I think security will take it and secure it in a locker until the patient gets discharged.
Right, right. And the patient's going to be very reluctant, if they're able to speak, to give up their firearm too. But just like, look, you can't go in the hospital with it. Law enforcement here, Officer Joe is going to take it. Let them work their process on how to do it. Yeah, get the PD involved.
I don't know if PD will take it unless they have, I think they might have to have a reason. So I think at that point, security in the hospital will probably take it. But I could be wrong.
Yeah, well, it's not, I think to Hunter's point, it's not your responsibility. It's not your responsibility, but it is your, like Luke says, it's in there with you now. So, yeah, call a helicopter. It's there with you, so you do have to make it. Do not, and I have to say this, do not try to disarm the weapon yourself. I have to say that. But if you're, let's just be real, if you're familiar with it, it's like, get this out. I'm not letting this ride on the cot and point at me while I'm trying to work on this patient.
Like you would not remove the magazine or chamber bound? You just don't touch it?
Yeah, I have to say that. I have to say that.
But in reality, yes.
But if I know what the hell I'm doing, I'm also going to make this thing. What would we call it? What would be the word for making that gun inert?
Condition 4.
Oh shit! I don't know what that means. Condition 4 means what?
Release the magazine and remove
The chamber.
Yeah.
So what's your take on that? And we're hearing it from a civilian kind of point of view. What would your take be?
I'm taking it off.
In condition 4?
No, I'll just get it out of his reach. I don't care what condition the weapon's in, as long as it's away from him.
Okay.
Where it could, he could reach for it, shooting. So
Default to the experts, all right?
that's what
That's my canned answer, Hunter. Refer to experts. Consult experts. And
you don't really have to worry about what condition the weapon's in. Just get it
as
out
long as it's not in somebody's hands.
arm's reach from the guy who's freaking out.
I have a question.
Uh-huh.
So you talk about scene safety and all that crap. So if there's like a shooting where you don't respond until the scene is safe and clear. My question is, say you're already on scene and you're treating a patient, and then
You can leave. You can leave. You can leave, and it will not be considered abandonment because the scene became unsafe.
Would you?
You
Or would you like just kind of throw them into the
What if, right? Yeah, what if?
I seen a video the other day of 2 firefighters who got
Well, Jonah, the point of that is, I think the take-home message from your question is, we suck at preparing you for that, and that's the reality of it. I told you I was reading this book, and I read a couple more chapters last night. And every time I read more of it, I'm like, okay, I wasn't the only one experiencing this. And I told you the other day I felt isolated sometimes, like I'm the only one who goes through this. Well, this was a guy in Atlanta, Georgia that was going through the same things. It's almost like I'm reading my own diary of the events he went into and things like that. So when he mentions things about crack burnt white lips, I knew from smoking crack and the burns on the lips, it just takes everything off the lips and just turns them into scar tissue. That's not in this damn textbook. You know? And the textbook's got this, this very sterile look to it, like, ensure your scene is safe before entering. Mitch, there isn't one that's safe when I enter. When I'm in that, treating that girl with a crack pipe in her vagina, and I hear the drug dealer scattering because the law enforcement's coming, I didn't leave her hanging in the window, right? You guys are going to be in there. And I think that's Luke's point. I mean, we can't run from everything we feel like we're unsafe with, because it's getting crazier and crazier out there. Crazier and crazier. One of the many unfortunate school shootings, and this one was several years back. I can't remember which one it was, but the point is, EMS did not go into the building because they did not know if the shooter was still active or not, if the threat had been neutralized. And it got so bad that they were taking markers and writing on paper, big sheets of paper and towels and stuff, and hanging it out the window and saying, please come in, the shooter has taken his own life. The threat's over with, but we need help in here. Nobody was going in because we didn't know if the scene was safe. And the bystanders were begging EMS to come in. The shooter's dead. He's dead. Come on in. Huh?
Why didn't someone come out? Or were they all?
We're all barricaded, locked in, locked down. Can't because they're shot up. I mean, whatever the cases are in there, but yeah, come on in here. And that looked really bad on us. I get it though. I'm not going in there either. And then you saw the video of the one down in Texas to where the ones that were supposed to go in were reluctant to go in.
Do you have to wait for PD to do this thing?
I don't know. Is that who you want to trust?
Well, I know on like say, violence disputes and stuff like that.
This is what's given rise to what we call cross-trained, or at least duplicate-trained personnel that are trained both in emergency medicine, law enforcement, and fire. And that's a great public service officer, isn't it? You put animal control in there, you got a 4 for 1. Hell, make them do garbage too on their off days. I mean, public service, right? But EMS is getting involved in scenes that are so crazy anymore. If you take what he's talking about, and that's what sparked the interruption. My bad for interrupting you. But when you take what he's talking about in military combat environments. What's the TCC stand for again?
Tactical Combat Casualty Care.
They're doing that in civilian world now. We have tactical paramedic teams that are going in on these high-risk deals like serving warrants and breaking down hostage situations and child abuse cases and stuff like that. So we're doing this here. And that's why I get so aggravated at the textbook or your skill sheet that says BSI, scene safe. It's not. It's just truly not. You're going to have car accidents where there's a gun on the dash or in the glove box or in the console, the door panel. You're going to pick up patients with guns and knives and mace and pepper spray and other forms of weapons. You can't stop every time you see something like that. You got to keep going forward. So what are you going to do? Well, we'll do what the book says in the test, or are you going to live in reality? And the reality is it's dangerous. That's the reality. And we could debate all day long whether EMS personnel should be carrying firearms or not. I personally think they should, but I also think they ought to have the training to go along with it. I think our system should incorporate, you should go to police academy before or after this, just like a lot of you are going to go to fire academy before or after this. Because you got to learn how to deal with this crazy variety of scenes. Go ahead, I'm sorry.
No, you're right. Yeah, so just going through this real quick. Massive bleeding.
So there's the bleeding, airway.
We couldn't really do much about junctional bleeds. They just kind of tell us apply pressure with gauze. But you know, each of us has 2 tourniquets on us, so those would go first. Airway, that would be the part where you remove the plate carrier. Every plate carrier has a quick release. You pull that, front plate comes off. Leave the back plate. That comes in handy if you have to do resuscitation. And then you pretty much checking the.
You're talking about body armor.
Yeah.
Body armor. Respiration, kind of similar to, I mean, just like XABC, exsanguination, airway, breathing, circulation. There it is right there. But instead of exsanguination, it says massive bleeding.
That's easier.
Yeah.
That's easier.
And then going into hypothermia, you know, hypothermia, particularly people who have lost substantial amount of blood.
We want to prevent that.
You want to prevent that. We tend to cover them in we have the space blankets too, so we cover them in those, wrap them up burrito style. Head injury is very common as well. Never remove their Kevlar or their helmet. That could be holding their head together, so you always want to leave that on. Just keeping their neck, head stabilized. Once all that's checked and good, you know, then you go into kind of your secondary care, which would be, you know, if they're conscious, treating their pain, giving them antibiotics. Battlefield's a very dirty place. Other wounds, and if they have injuries requiring splints.
Yeah. That's care of a trauma patient. That's absolute care of a trauma patient. The differences in civilian world is we're going to leave the antibiotics to the hospitals, but they're in the field, they don't have time. That's much better than, I'm going to show you one of the worst things in EMS. It's this acronym, this abbreviation. I hate this with everything I have. If you come to me and tell me you're assessing your patient for DCAP BTLS, I might scream or go home. This came from a course called PHTLS, Pre-Hospital Trauma Life Support. I predate this damn abbreviation. We did fine without it. And then we went into this other trauma course, and they came up with this: deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Is that not just anything that's abnormal? And so when I would check patients off or students off, and they go, I'm checking the scout for DCAP BTLS. And I'm like, what's that? And they can't even recite what the abbreviation stands for.
They're looking for that.
I'm just looking for something that ain't right. Why do we have to make it so hard? And I love your acronym, basically because it just gets to the point. And whether you're ALS, BLS, military, non-military, is that not true for all trauma patients? And I think so. So thank you for sharing that. However, if you went to another EMT school and they said, did Brandon teach you about DCAP BTLS? Like, I never heard of it. They're going like, well, you went to the wrong school because they didn't teach you anything. You've seen it, but it's kind of like AEIOU tips, all the things that can cause a seizure. So, yeah. And the rest of this is just pretty straightforward stuff. And I know I'm going a little bit backwards here, but the internal bleeding for us is the worst because it's so hard to control. In other words, we can't control it. Now, at the paramedic level, the only thing they can add to it is that drug TXA, that tranexamic acid. So if ALS is readily available, you might get them on scene for internal bleeding because of TXA. But if it's not given within 5 or 10 minutes, it's probably not effective anyway. So don't delay transport waiting on TXA. But that's about the only thing the paramedic's going to be able to bring to you. And it may or may not work. We don't even really know if the studies are still out on it. It's a relatively safe drug. It got its start in surgery. So when you go to surgery, they give you that. A woman who has very heavy menstrual flow, heavier than normal, they will prescribe that for her to help tamponade or control some of that hemorrhage from the menstrual cycle. And so it's made its way over into EMS, and we give it to our bleeding patients, internal or external, but it's about our only method of internal bleeding control. Internal bleeding that is serious must require surgery. You have to be opened up, you have to find the source of the bleed, and you have to repair it, and then you have to fill the container back up with what was lost. And hopefully any tissue that was damaged can be salvaged, removed, or at least have some form of life afterwards without it, whether that's an amputation or a kidney removal or partial liver resection or something. We'll deal with it when we get there. What is not being perfused during these blood loss responses? Now, we've been talking heavily about what is being perfused. What's not being perfused?
Muscle is.
The outer
It,
extremities.
some of the muscles getting lost, but remember, alpha 2 keeps that from totally shutting it off.
Skin, right?
Alpha 2 is keeping that from totally being shut off, but yeah, we are shunning it from the skin, but the skin can survive a long time without blood flow. What is like absolutely shut off? Yeah, the gut. The arteries that feed the gut are closed off. Therefore, post-incident into the recovery phase, what sets in? Sepsis. Because the wall of the gut becomes porous. The gut itself is dying, and so the patients often end up septic. So if the kidneys make it through it, and the liver makes it through it, and the lungs make it through it, then the next step is that you got to battle is worrying about sepsis 5, 6, 7 days post-incident. And he already said the battlefield's a dirty place. Some of these crack houses are pretty dirty too.
Not even just crack houses.
Just houses in general. And I'm not talking about anyone. It's not for me to judge. I've been in a lot of houses, and people are filthy. People are just filthy. People you would not think are filthy when you go in their homes. And it's like, oh my God, how long have you been shitting in that toilet? Without a flush. Without a flush. I've been in houses where one whole bedroom was covered in sand for the cat's litter box. And that's cats with an S. It's like, what the hell? So filth is prevalent anyway in these environments. So outside of sepsis, another post-recovery incident, and I want to go ahead and tell you about this while it's on my mind, is a disease process or a physiological process called ARDS. Acute Respiratory Distress Syndrome. Acute Respiratory Distress Syndrome. So if blood loss becomes so severe that your clotting factors are used up, do you remember me saying something about during anaphylaxis, you get a local bee sting, but the whole body responds to the bee sting? Sometimes in blood loss, it gets so severe so fast that the whole body responds to the blood loss. In other words, it activates all of its clotting factors. All of the clotting factors. When you activate all the clotting factors, you have none left and you start bleeding everywhere. That's called DIC. You ready for this? Disseminated intravascular coagulation, DIC. Disseminated intravascular coagulation. all clotting factors get used up at once because the body is just trying to live. And it says, that's a severe bleed. Here are all my clotting factors. Please fix it. When the body dumps all of its clotting factors, there's nothing left anywhere else. So now we get an imbalance in the capillaries. And they start leaking. They start leaking. Where are there lots of capillaries? In the lungs. So we start leaking plasma into the lungs, and the trauma people call that shock lung. It reminds me of when we do the pig trach thing over here one day, we might run across one. If we run across one, we know that pig didn't get bled properly. You'll know when you run across that lung because it won't be like a fluffy sponge. It won't feel air-filled. It will feel like a wet towel. Shock lung feels like taking a bath towel and submerging it in a tub of water and pulling it out and throwing it on the floor without wringing it out. Just take a bath towel, submerge it, get it fully wet, and throw it on the floor. That's what the lungs in ARDS patients look like.
It's called lung what?
Shock lung. Acute respiratory distress syndrome, aka shock lung. And that can occur hours to days post incident due to probably DIC. Used up all the clotting factors and it just started leaking out the capillary beds. Survivability is not good. Don't pat yourself on the back with trauma victims just because you got them to the hospital breathing and talking. We'll know in 3 or 4 days. Some of the stuff is delayed. Will sepsis kill them? Will shock lung get them? Will DIC get them? Will a blood transfusion get them? Will liver failure, kidney failure? Not out of the woods just because you made it to the trauma center.
What is DIC?
Disseminated intravascular coagulation. Okay. The importance of stopping the bleeding. I want to talk to you about some bleeding that is caused by non-traumatic causes. Because the traumatic causes are pretty straightforward, aren't they? You got hit in the gut with a baseball bat. You decelerated and struck a tree at 70 miles an hour. It's pretty obvious what's causing your internal bleeding. We need to talk about the non-trauma causes of internal bleeding since we're on that topic anyway. Bleeding ulcers. There are people who have ulcerations in their GI tract that can get to the point where they start bleeding, and they can bleed to a life-threatening level. When they vomit that blood, you think you can come up with a name for it?
Hematemesis, something like that.
Hematemesis. Very good, Gus. Hematemesis. Vomiting up blood. Specifically, these terms are going to be found on page 941 of your text. So, a lot of that verbiage I talked about earlier, Frank, that we need to be familiar with. So 941 in your text has these terms. Hematemesis, the vomiting of blood. If it comes out of the other end of the GI tract, it's called melena, M-E-L-E-N-A, black tarry stools. Black tarry stools. Yes?
What would cause hematemesis in like someone who's like 40?
It can be anything from just a incorrectly built atrioventricular junction, like a shunt that malformed. It can range all the way up to eating one of those little button batteries and getting that in your gut and it burning a hole through the gut lining. Foreign objects being swallowed. I mean, the list is long.
It happened to me. I don't know what did it.
Did you eat a battery?
Hematemesis is throwing up, or
Throwing up blood. What, they didn't find out what it was, or?
I don't know. I asked my mom. She didn't know.
Some people will vomit so hard that they will retch a vessel in their esophagus or their upper stomach, and that will bleed. So if you'd been throwing up a lot prior to that,
I don't know. I was like 4. And
you don't remember. You probably don't remember the events, do
You
you?
might have just got. No, I remember it happened. I just remember being over a bucket with my twin, puking blood.
Was the twin puking blood too?
Yes.
Damn.
It was a blood moon.
You both ate batteries.
Damn.
I've never eaten a battery.
Both twins were vomiting blood at the same time.
That is one stressed.
Ooh. I have no idea on that one.
Craig, what's your brother's name?
Henry.
Makes sense.
Does it look like you still?
It depends on who you ask.
Are y'all identical?
You're born identical.
Melena, black, foul-smelling, tarry stool that contains digested blood. You will be in the patient's. Oftentimes, you find them in their own bathroom, and they just can't take this anymore, and they pass out because they've been losing blood internally. But when it goes to the GI tract and it comes out the other end, it's black and tarry. And I don't know why. I think it's the amount of toilet paper they use to try to clean up. They stop up the toilet, because I've always found a pile of that toilet paper next to the toilet in either the trash can or on the floor. And it looks like you took a bucket of tar and just dipped toilet paper in it. And they're using so much they don't flush or can't flush or stop it up. And it's like, oh, there it is. There's Melena. She met me at the door, and you know that this patient's been bleeding a while. And that blood can be significant to put them into shock. Hemoptysis, that's on 941 too. Hemoptysis is the coughing up of blood. The coughing up of blood. Hemoptysis, 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 coughing up blood. So you know something in the airway is damaged or open or bleeding. This can be from a gunshot wound to the chest. Obviously, you'd be coughing up blood. And all the way to and I told you about the guy who inhaled a piercing and was coughing up blood. He had hemoptysis. So he was a trauma patient. Hematoma. The registry loves to use the term hematoma. Hematoma is a blood-filled tumor. Basically, that's what hematoma is, a blood-filled tumor. That is not necessarily a bruise. A lot of people confuse that with a bruise. A bruise is called ecchymosis.
How's that smell?
Ecchymosis?
Yeah.
ECCHYMOSIS. Ecchymosis. Also known as a contusion. So contusion, bruise, ecchymosis, same thing. Hematoma, blood-filled tumor. You ever had a blood blister? That's a hematoma. And they can get big. Hunter, my cow still has that something-filled tumor on her neck. Was it you I was talking about? No, it was it's still there. I need to lance it, I guess. I just don't want to stress her. Hematuria. HEMATURIA. Blood in the urine. So if somebody's peeing blood after a car accident, they have suffered a bladder injury or a kidney injury or a ureter injury. That's why it's against the rules to punch somebody in the back in boxing, because you can hurt the kidney and they'll pee blood. So with all of that, you have both trauma-related causes and non-trauma-related causes. Sometimes you have to kind of play detective and like, have you always been? Yeah, I've got stomach ulcers. Okay, well, that's where the blood's coming from. I've got a urinary tract infection. That's why I've got traces of blood in my urine. Okay, then it may not have been a trauma-related thing. But it's still blood loss. So we can't forget that. It's still blood loss. Ruptured ectopic pregnancy, once again, it's worth mentioning because it is such a life threat. Any woman of childbearing age with severe abdominal pain is ectopic pregnancy until proven otherwise. Pregnant women and trauma. Pregnant women and trauma. Is there a high risk of blood loss there? Yeah. Can you rupture the uterus? Yeah. Gravid uteruses. Is it uteruses or uteri? A gravid uterus means a pregnant uterus can rupture, especially in the later trimesters because it's stretched so thin. The signs and symptoms of that, you will see an imprint of the baby's foot or hand or face in the abdominal wall of the woman. The baby is outside the uterus now. And for a little bit, you may even see the baby pressing on it like, I need out. The baby will die quickly. So don't be a hero there. The baby's going to die very quickly because of the blood loss. When it comes to trauma and pregnancy, I hate to say this, but I'm going to say it. And this is the mindset you got to get in. And it upsets some people when I say this. So forgive me for being bold. When dealing with trauma and pregnancy, the baby is a parasite. And it truly is. To get pregnant means to be infected with a parasite. Because that thing locks into your uterine lining and it sucks nutrients from you. In the event that the host is physiologically stressed or in a shocky condition, especially a decompensated or irreversible, what will it shed in order to preserve itself? It will shed the parasite. We know that as the fetus. But I need you to think of it that way because if you're going to keep that baby alive, then you got to keep the mom alive.
So let's say, like, you get to the scene and there's a pregnant woman, but she's like, I don't know, let's say like suicide. So she's for sure dead. There's a lot of blood loss. What would you do?
Nothing.
Yeah, maybe that one.
Pray however you pray, I guess. Pray however you pray. Buried off in the recesses of the American Heart Association Advanced Cardiac Life Support course is probably a 3-sentence paragraph that mentions an emergency C-section thing. It's probably not going to work. It's only going to work like if there's the pregnant woman and she's term with the baby and she dies right in front of you, you got about 5 minutes, But outside of that, they just want you to do good compressions, good CPR, rapid transport to a facility that can take care of it. I don't know if that's where you were at in your head, but if she's pulseless and apneic when you get there, chances are she's shed the parasite already. And that's that alpha-1 stuff going on. That's that hormonal response to the shocky condition that the host is in. We're shutting off blood to the non-vital organs, right? And in that scenario, that's a non-vital organ. Gosh, it's hard to say this and be real yet be sympathetic to the issue at large. That can be replaced. That's how the organism's looking at it. I can't replace the brain or the liver or the heart or the kidneys, but that's expendable in a trauma environment. Y'all understand what I'm trying to get at there? And it's horrible. I mean, I don't even like saying it, but it's just the way it is. there was one more thing I was going to mention about pregnancy and trauma. When you transport these heavy, late-term pregnancies, women who are to the point you can tell they're pregnant by looking at them, they should be transported tilted to the left. They should be transported tilted to the left. And the bigger the uterus is, the more important that becomes. If you put them supine or flat on their back, that uterus will set down on the vena cava and it will keep blood from returning to the heart. And that's even more compounded in a shock environment or a blood loss environment. So we want to turn them to the left. There's two reasons to turn them to the left. One, the vena cava is predominantly more on the right side of the spinal column. And number two, if I turn them to the left, they look at me in the ambulance, not at the other wall, so I get a better visual of them. I always thought that was the reason we turned them to the left, but it's not. There's an anatomical reason. It's because the vena cava tends to be toward the right side of the spinal column. If all you could do is turn them to the right, that would help too, but you just don't want them flat on the back because that puts pressure on the vena cava. We used to say tilt the backboard, but we don't put people on backboards, so you could just prop them up with a pillow. And it doesn't have to be fully on the lateral side, just that way.
Those patients screams when you tilt them to the left.
Yeah, we don't want to cause anything else. If there's something preventing it, try the right or set them up. Those are other options as well. So we've been through these terms before, signs and symptoms of internal bleeding. So we don't have to go through that anymore. Remember that we don't have bleeding without other trauma. In other words, we have soft tissue trauma, we have skeletal tissue trauma. When it comes to trauma and bleeding, we have to be aware of the other injuries and what's actually causing the bleeding. And so that gets into bandaging soft tissue wounds. And y'all kind of did a little bit of that the other day. And it requires splinting of skeletal wounds. So methods of bleeding control: direct pressure, packing, tourniquets, TXA at the advanced level, splinting. So if you had to list all the ways to control bleeding, make sure you include splinting of any deformities. Because broken bone ends, bones bleed, and then they rupture other areas as well. And think about your femur right next to the femoral artery. Pelvis, two huge arteries in the pelvis. And so those need to be splinted as well with pelvic binders and the such. So we've already been through the signs and symptoms of bleeding. And whether it's internal or external, these signs will be shared. Make a little point about cap refill because the test questions revolve around that. Capillary refill, which is basically just take your nail and squeeze it and turn it white, and it should go back to pink really quick. That's a real good indicator in children, less reliable in adults. You can use it, but it's less reliable in adults than it is in children. We're calloused up, we've beaten our hands up and stuff, so it takes a little longer than it would in a child. But the cutoff is 2 seconds. So under normal conditions, the pink color should return within 2 seconds. If not, something's off. So there's Luke's scene safety. Thank you for that once again. That's good. I like the way that sums it up. It's no longer spinal immobilization, it's spinal motion restriction. And securing them to a standard EMS stretcher is considered spinal motion restriction. Backboards are only going to add difficulty and pain and cause secondary injuries themselves. You can use a backboard to carry them out of the ditch across the field, but once they get to the stretcher, they're off the backboard, secured to the cot. If you have a vacuum mattress, that works awesome if you have definitive spinal cord injury, the numbness, the paresthesis, and things like that. It's like, I know he's got a spinal cord problem. High suspicion of that. A vacuum mattress works well, and we'll get that out soon in one of our lab days and show you how to put them on that. The only reason I will allow anybody to show you how to put a patient on a backboard is for moving them across the field. It's for patient movement only, and it's also good for CPR because you got to have that firm surface under the back to do compressions.
So what did it used to be used for? Is that what you would take?
That's what we taped everybody to, like a damn papoose. I mean, we had them wrapped up, duct taped down, you couldn't move. And just imagine lying on that desk, tied down to it to where you can't even raise your head up for 20, 30, 40 minutes, if not up to hours. We have to get you to x-ray first to make sure you don't have any. Well, I'm unsure about the x-ray. I'm going to have to let a radiologist read it. Well, I want the neurologist to read it. Within about 45 minutes, you already have necrosis or bed sores. You have neuropathy from the nerve endings in the lower part of the spinal column. Vertebral fractures in women who have osteoporosis when you try to get them flat on a board. It was horrible. It was horrible. We knew it was horrible when we were doing it because people would scream out in that pain. There are still some services doing it, and it needs to stop. Do not be distracted from identifying life threats, meaning if that angulated ankle fracture that's got two bone ends sticking out of it is drawing your attention away from the fact that they have a flail segment in the chest or they get this big bruise starting over their liver, you're making a mistake. I often say, if it's so gross you don't want to look at it or it's drawing your attention, cover it up and go look for something else. Go look for something else. And we've already hashed out the splinting to death rule anyway, so don't splint to death. XABCs, please check the breath sounds. We can be so worried about controlling bleeding that we're missing a hemothorax or a pneumothorax, and we'll talk more about that when we get into chest injuries. Because after this chapter, we start going system by system in trauma, and that'll be the remainder of the trauma lecture. And then treat for shock, which is what? Getting down to the treatment of shock. What is the treatment of shock? Keep them warm. I think that also means do not allow them to get cold. I don't think we want to warm them up to the point where they're sweating, but we don't want them to get cold and shiver either. Coagulation of the blood or blood clotting does not work well when the patient is cold. So keep them warm really means prevent hypothermia. And remember, they're shunting blood to the core, so they're losing that ability to do so. Fluids, I still hear fluids being preached in paramedic training sometimes, and current practice is, and you don't have to worry about this because you're EMT, but in paramedic school, current practice is permissive, same thing, permissive hypotension. We let the pressure run low purposely. We do not resuscitate blood pressures. We resuscitate little toes. When the little toe is warm, pink, and dry, my treatment for shock is finished. Does that make sense? There's no more vasoconstriction in the furthest, most expendable region of the body, the little toe. The evolutionary biologists feel like within so many years we won't have a little toe anyway. We'll just have remnants of something of it. Yeah, lost both toes. Lost its significance evolutionarily speaking. With that being said, we resuscitate the little toe. Now some people look at you and go, what the hell are you talking about? But those who know are like, that's a smart dude right there, or that's a smart girl. That's what we resuscitate, that little toe. That tells you everything else is taken care of. When the body says, okay, let's go feed the little toe now. Everything else is good. I can get a blood pressure on a dead man. So, with that being said, do not resuscitate a blood pressure. There's your XABCs once again. And at some point in this, you've got to determine, is the blood loss so severe that we're going to transport immediately? And oftentimes it is. So When in doubt, transport. And the rest of this just goes straightforward stuff. 5 and 15 on your assessment. 5 for unstable, 15 for stable. I would caution on the high flow oxygen. Certainly something to be considered. Your pulse oximetry is going to be inaccurate, isn't it? Because you're shunting blood from the nail bed, so you're not going to get a good pulse oximetry reading. What would be a better thing to read than pulse oximetry if you really wanted to know about how the organism was metabolizing? Capnography. And I just do not hear that preached even at the paramedic level too much. I can put a capnography on a shock patient, what will tell me if they're going into anaerobic metabolism a lot quicker than a pulse oximetry will. Matter of fact, the only way.
And that's the thing where it measures
The CO2 coming out of your blood. So if I started getting really high CO2 levels coming out of my blood, that tells me that the body's trying to compensate for a lack of perfusion to certain areas. Or if I do start resuscitating the patient, all those extremities that have been without blood supply regain their blood supply, I would get a lot of CO2 coming out then because I'm cleaning things up. It's kind of like taking out the trash after Christmas morning.
Capnography is the CO2 output, correct?
Yep. Yep. And that's all we can do pre-hospital wise. In the hospital, they can do blood gases and they can measure amount of red blood cells and platelets and all that stuff in the blood. We can't do it. So careful with the high flow oxygen. I think your current treatment will tell you not to do that unless definitive hypoxia is present. So we know this direct even pressure elevation, that's kind of left by its side because it's really hard to hold somebody's foot or arm up all the way to the hospital. Minor wounds, yeah, it'll stop it. Pressure dressings or splints. The registry is going to test you to see if you will move quickly to a tourniquet. So if that's an option out there, I think I would go for it. I don't know that I'd do it for road rash, but if the option of tourniquet is there, carefully consider it because the registry is really wanting you to not hesitate to use the tourniquet. So if you see that as an option, I think I would have to seriously consider it. There's that powder inside that dressing that helps it, and then wound packing, and you guys done that with the other day when you were packing the wound. I have had this question before. Should you pack torso wounds? So if I've got a wound in the torso, do you pack it?
You just cover it.
They told us
That's
in
what they told us yesterday. I mean,
Israeli man. That's what they call it.
we used what's the Israeli bandage?
When packing it, like cut off blood flow or something?
Why'd he bring it up? Why'd old Brandon bring this up? Do you wound pack a leg wound? You can. Do you wound pack an arm wound? Can. What about a gunshot wound to the head? No, he's not dead. He's just massively hemorrhaging out of his nose. It hasn't went into the cranial vault.
We just tape this bandage to your base real quick, sir.
It's just like
You can pack it.
took part of the scalp off, but didn't penetrate the skull.
Yeah, it's a facial gunshot wound.
if it didn't penetrate the skull, you should be fine.
Yeah, I'm not talking about packing into the brain, but
Because the point is you don't want to put pressure on those internal vital organs, right? Kneading is what they call it. Use your fingers.
packing material into torso wounds. There's a reason they say no. And if you look at the Stop the Bleed course, which all of you, you did the skills Stop the Bleed the other day, and there's a little course you can take. So you have a certificate. and it just adds to your portfolio of things that you can do. But Stop the Bleed course does not want you to pack torso wounds. That is also a lay person course, okay? That's what we would teach an entire high school student body and staff and teachers and faculty to do in case of life-threatening hemorrhage. They don't want you packing the torso because they want that time spent moving the patient to definitive care. Because how do you prove its effectiveness? That's the reason you don't pack a torso wound. How do you prove its effectiveness? And that time spent should be better spent moving to definitive care. However, in surgery, when something goes, uh-oh, they will grab massive amounts of gauze and pack the wound that they created until they can get the hemorrhage under control. So, like anything in medicine, don't take a hard left or a hard right. Don't take a hard yes or a hard no. It's got its application. Is it the best option? No. The stuff that's considering the best option would be moving them to definitive care. Plus, you don't know if you've actually stopped the bleeding. But it could be effective is what I'm getting at. So I address that because that question comes up quite a bit, and you'll have people say, oh no, never. And anytime you hear, oh no, never in this business, you're probably talking to a fool. Because medicine is anything but yes, no, always, never. Agree? You figured that out so far, haven't you? Okay, if your pressure dressing doesn't work, do not rip it off. Just add more to it or tie a tourniquet. Some of the disadvantages of hemostatic agents may be clot formation that travels and becomes a PE, but that is a risk anyway with bleeding if the clot busts loose and goes to traveling through. So don't let that be something that hampers you from doing it. Junctional tourniquets, you know where they go, the junctions between the torso and the legs. Air splint can also be used as a tourniquet and also applies direct pressure. This is just a big bladder that goes over the limb and you air it up and it makes it tight, kind of like a big blood pressure cuff. The problem with these are they leak and the bleeding can start again. So it's kind of fallen out of favor. If you need to splint an arm and control bleeding, it might work pretty well, but always be aware that pressure changes. You put that guy in a helicopter and he goes up 1,000 foot, it's going to change the pressure.
It's going to
They're-
get a lot tighter. Or
Yeah. Yep. Get tighter. Like a bag of chips going to Colorado. Don't buy your groceries in Texas and go to Pikes Peak. Buy them up there. We were driving back from the seashore in Northern California and we'd bought 2-liter soft drinks and we never opened them. And so we put them in the car and I got somewhere in California and I looked at the elevation. We're all of a sudden now at 12,000 feet and I'm like, so we stopped and got gas and I offered these guys that were working on a construction, I want some Cokes. Open them slowly, please. I bought those at sea level and they're looking at me like, why are you giving us soft drinks? And what's it matter that they were bought at sea level? Can you imagine those rupturing in a car? It would total an interior. It would literally total an interior. And we have to think about that stuff too. If I intubate a patient and I put air in that cuff, and then they go into flight, it can get so tight it causes a bed sore in their trachea. So I don't fill it with air, I fill it with saline because saline won't expand. And that works with the air splint situation as well. These can expand and get too tight. I don't like them. We don't use them often enough and they deteriorate and they just leak. They're a pain in the ass. And I would rather see EMS spend money on pelvic binders. So any agency you go to work for, I hope like hell they have pelvic binders. If they don't, you're going to have to improvise and you can take a bed sheet and fold it up to about the width of the pelvis and tie it down. That's very crude and elementary. But when you've got that, what we call an open book fracture of the pelvis, when you press down on the pelvic wings, it just lays out. There's no stability. Quit pressing. Stop that. It's not stable now, and they need a pelvic binder because those iliac arteries can get pinched up into that pelvis, and you could lose several units of blood right there. Another term that people often miss is the ones that come from the nose called epistaxis. Epistaxis. Epistaxis is nosebleed. And for your purposes, we control a nosebleed by pinching the nostrils and leaning the patient forward. Ding, ding. Pinch the nostrils, lean the patient forward.
What's the difference between that and rhinorrhea?
Rhinorrhea, if you go, that's rhinorrhea. That's just runny nose. Good question, though. One of them's just mucus, rhinorrhea, and the epistaxis is the blood.
Why can't you lean back?
The blood will drain into the airway. But how many people do you know get up a nosebleed and do that? There's an artery that feeds at least the front part of the nose. You can press real hard right there and control that artery. In the hospital, they'll use tampons, rhino rockets. They go in there and tampon out. In severe cases, they'll use cocaine because cocaine is a potent vasoconstrictor, and they'll just squirt cocaine up in there to constrict the vessels. Do not allow your epistaxis patient to blow his or her nose. Use and abuse of nose drops, dried or cracked nasal mucosa. Have you ever seen the old man who's addicted to that little inhaler thing, that little Vicks inhaler? I've seen a couple of those old guys. They carry it around in their pocket. They'll just, man, I just get stopped up. No, you're addicted to that damn thing. So that dries out the mucous membranes and will cause nosebleeds. There it is. There it is. What demographic of patient would this bullet point fit? It can cause enough blood loss to send a patient into shock. Okay, what else? Person on blood thinners. And it's really weird, those people end up like in high-level trauma centers. They go get a stent because they've had a heart attack, an MI, so they get on blood thinners. They go out and mow the lawn again because that's what they like to do, and they feel so much better now that they got their heart fixed. And they go out and mow the lawn, and a tree branch smacks them in the nose, and their nose starts bleeding, and they end up a week and a half in MCP Plano trying to get that to stop. And anytime they remove the packing, the bleeding starts again. True case, old guy I know, it just happened to him. And it became life-threatening. I mean, he was fine, but the blood thinners, when he took the blow to the forehead or to the nose from a tree limb, mowing his grass like he wanted to do, once you get on those blood thinners, guys, your lifestyles change drastically. Drastically. I'm going to tell you about this, but it's another one of those things. It's like, okay, so what? If you got blood coming out of the ears, I want you to be highly suspicious of a skull fracture if the mechanism of injury leans that way, or highly suspicious of that blast injury, that pressure wave, that primary blast injury coming over your eardrums and rupturing them, or heaven forbid you were in an airliner that lost cabin pressure, or anything that would cause your eardrums to rupture can cause bleeding. But if the mechanism of injury is a fall with a blow to the head and you got blood coming out of the ears, think skull fracture. If you see bleeding on the mastoid bone is behind the ear. It's called a mastoid process because it sticks off the skull. That's called subaurical ecchymosis, auricle being the ear, under it subaurical. EMTs call it battle signs. So if you see bruising behind the ear, that's indicative of a skull fracture too. But that's a very late finding. So if I find that on a patient, that skull fracture, that incident happened a few days ago. That's a very late finding. But coming out of the ears is a relatively early finding in a skull fracture. There is a test to see if it's a skull fracture or not, and that's called the halo test or the target test. And you take a gauze pad and you blot that fluid coming out of the ear, you blot it. The blood will stay in the center. If you see this pale yellowish fluid that's creating a halo or a target around the blood, that is cerebral spinal fluid. So it means the meningeal layer has been ruptured and that fluid's leaking out along with blood. If it's kind of like a tilt test. If I suspect and I take the time to do this, what have I not done? Yeah, I need to be moving. I need to be going with the patient. Are you starting to see why that opening line yesterday where I said you're better off to go by your buddy? You got all these tests for this, right? We could even tilt test them to see if they're compensating or not. We could spinal immobilize them. We could try direct pressure. We could do a halo test with this blood coming out of their ears. All that stuff is meaningless. We can start 2 large bore IVs. That's even worse because then we start diluting the platelet load. Hey, you got them on the cot. It's a white sheet, white pillow, or whatever the case may be. Or maybe you try to control bleeding and you notice it. Okay, you did a halo test, but you didn't do it intentional, but you notice it. But I'm not taking time out of a major trauma victim to see if this is not. There's even one where you can take a glucometer and get it. And I think cerebral spinal fluid has a really high glucose reading because the brain likes that glucose. You're wasting time. You're wasting time. But now you know that it's out there. Now that you know that it's out there. Okay. The bottom line is we got to get them somewhere important. And we haven't had this lecture yet, and I've been pausing this lecture because I want Emily to give the lecture. And there's a possibility she will be your sub next week. And if she is your sub next week, that's the lecture she will give you. And that would be on Monday. If she doesn't turn out to be your sub, I will have her in here at some point to talk about what it means to do a trauma center. We also have a group exercise where I have 4 different scenes, 4 different patients, 4 different maps, and I just randomly dropped a pin on the Texas-Oklahoma map, and this is where your incident is, and you have to work through that patient injury and you have to pick their appropriate trauma center. So we need to talk about those because we have destination issues that we got to deal with as well, and that's part of being an EMT. There is a test coming up Wednesday. I looked this morning for the review because I know I have that review typed somewhere in PDF format, but
Next Wednesday.
Yeah. I could not find it on my desktop this morning, so I'm going to scour previous Canvas shells because I know I have sent it to other classes. And I may just be totally overlooking, maybe on a thumb drive, maybe in Google Drive. There's so many places to throw it.
What test is this?
It's medical emergencies.
What chapters?
Up until 25.
All of them.
1 through 24, basically. But I'll get that review out to you.
Next Wednesday, right?
Yes. Tomorrow we do 27. I think that's soft tissue.